Something else that I think is valuable to have written into that plan that you discuss with the team and then even go into the hospital with your written documentation of, what the plan is and that your endocrine or your maternal fetal medicine has kind of signed off on you managing. The second piece to that management is often the spouse or the significant other, the partner, also knowing what the plan is. Very much encourage the partner to understand the button pushing, where to find things in the pump, especially. If you're MDI, it's a little bit of different written protocol. But if you're on a pump, and that partner should really know at least where to find what your system management strategy is, what buttons to push again.
Welcome to Think Like a Pancreas, the podcast, where our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in this program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Please discuss any changes to your treatment plan with your personal healthcare provider before implementing.
Good morning. Welcome back, or good afternoon, depending on when you're listening to this. This is Think Like a Pancreas, the podcast. And I am Jennifer Smith. I am a registered dietitian, certified diabetes care and education specialist with Integrated Diabetes Services. And I'm back again with one of my favorite clinical counterparts, Tavia. And this is episode 3 of 3 as we're talking through navigating preconception planning, pregnancy planning. And now we're sort of moving into that birth and beyond, sort of navigating that labor delivery time, as well as how to plan for your postpartum sort of future with your new little person. So thanks for joining me, Tavia.
Yes, thanks for having me. Thanks for joining me too. So I'm Tavia Vital. I'm a registered nurse certified diabetes care and education specialist with Integrated Diabetes Services. And Jenny and I help women manage their pregnancies, preconception through managing diabetes all the way through the pregnancy and planning for this very exciting time of getting to meet the baby or babies as it may be
Yes.
on the outside. And that is what we're here to talk about today. But Jenny, what do you think is important for women to know before they're going in for labor and delivery about what the hospitals might have in mind for managing their diabetes while they're there for labor
Yeah.
and delivery?
It's a great question. It's usually the reason that in working with somebody during their pregnancy, we try to focus somewhere around 30, 32 weeks on a labor and delivery plan, which addresses, and I usually set women up, as I know you do too, with the idea that even coming into that appointment, they should have already talked with their OB or their delivering team about what is the hospital protocol for labor, delivery, and postpartum for a woman with type 1 diabetes. Because while there's a general way that most systems manage, that protocol is a little bit different place to place. Some places have very, very strict rules, and others are a little bit more sort of fluid. They allow it to be navigated as well, along with the diabetes management plan that the woman with diabetes essentially has. So it's really valuable for you to talk with your team and know what's the protocol, and then how much sort of wiggle room is there for the woman to actually continue to do her own management if everything is looking well set.
Right. If everything is going according to plan, can the woman self-manage their diabetes if that's something that they want to do?
Correct.
And I think you and I are both on the same page that we both recommend that strongly, as long as mom and baby to be are doing well. And
Yes.
it's not a case where maybe mom needs to be put on magnesium and they're so tired they can't keep their eyeballs open. There's no way they could manage their own diabetes. Well, then, of course, then you'd want to transition to the hospital protocols. But aside from that, most of the time, if somebody has been working with us already, we know and they know they're capable, very, very capable of self-managing their diabetes well. And we've talked through with them what they can expect as far as insulin needs heading in. I think that is important, talking to the team ahead of time so that you know what their plan is. And then if it wasn't an opportunity in that first discussion with your delivery team, the OB team, then working with us, we can help you figure out a way to present what you want if it's very different from what their protocol is, and just ask if it's a possibility. And sometimes people go into those visits and they say, I don't, they seem pretty strict with their approach. It seems like it's very well outlined and this is what they do. But
Right.
sometimes after presenting their case, so to speak, like, okay, understood. And also, my glucose time and range has been amazing this entire pregnancy, and I'm healthy and baby's healthy. What would it take to allow me to self
Keep
manage?
managing, right,
Yeah,
and that's where I think the letter that we both it's more of a document that we both provide as we work with women around that discussion of labor and delivery. The document really includes, this is my labor and delivery plan based on my diabetes management strategy. This is the system I use. These are the products that will be on my body. These are my targets that I'm aiming for. This is how I plan to navigate this type of situation, almost a if this, then that. And I would say that most teams feel very confident then when they get a document like that from their patient, so that they can tell the person is not only well informed, but they also know what to do, how to really use their product. If they haven't seen that all the way through the pregnancy up to the delivery point, this document really is valuable in pointing to the patient really knows what they're doing. And it's in their best interest to have the insulin doses and the strategies that have been sort of put together as we work with somebody. What's the best frame to kind of keep things contained. And we might have several different navigation sort of tools in place for different scenarios that may happen during the labor and delivery process. Some women end up seeing a more like kind of a continual slide down in insulin need the longer laboring goes on, because it becomes like a long duration sort of, it's like a walk, or I usually compare it to if you've ever been to a theme park. You start
that's a
out the
great one.
day in a fine place, you're walking, you're waiting and standing in line, you're walking more, you're going to get food, you're walking more. Like if you've ever been to Disney World or Universal or any place like that, by about a 2 to 3 hours in, if you have not made an insulin adjustment with a temporary basal or a cutback or
You will be so
temporary,
low.
you will be low the rest of the day. Labor, similarly, is an ongoing progression of the contractions, the baby's movement down. It's a lot of muscle use that most people don't think too much about. And if you are somebody who doesn't get an epidural or waits until like the last moment that you can get it, you may have also been somebody who feels better up and moving. Maybe you are walking, maybe you're bouncing on a yoga ball, maybe you are in a warm water kind of pool and moving. All of that increases, along with the contractions, your insulin sensitivity. So we really work with people to have a plan of action for whether it's a pump or multiple daily injection. How do you navigate that sensitivity as it comes back in, to let the team know in, again, that document that we provide, so that the team knows exactly what you're going to be planning to do, and they have a little bit more confidence then in navigating that. I also usually recommend bringing along, for those who are using more of an AID that's like a DIY kind of AID, I recommend bringing along a laptop so you can have open your data so that as it's changing, your team can see it. You also have a much bigger screen to pay attention to things. You could do the same thing on many of the other systems, even just having your CGM data open with a phone on a charger so that you can kind of see that line rather than having to continuously like open your phone or your device.
Pay attention to it. Yeah,
I find that the clinical team seems to really like having that visibility as soon as they come into the room to see things.
absolutely.
So
It's just it's on everyone, at least it should be on everyone's mind how the mom's glucose is doing during labor and delivery, and just to make sure everything is as safe as it possibly can be, and that there's enough glucose on reserve to continue the labor successfully. But also, there's that fine line of trying to keep glucoses below
Tight.
that, yep, in that tiny pregnancy range to keep things as healthy as possible for baby while they're still in there. So
Hmm.
it is a great idea to have it displayed, glucose displayed. And another thing that I recommend is if they have someone in the delivery room with them, then to have them be on share. Like if they're
Yeah.
using, for example, Dexcom, you can have a Dexcom follow where you
Hmm.
share the data. So you have another adult who's aware of your diabetes. And if it's a partner, then you've also shared with them what your insulin plans are and when you plan to shift to the next step of the plan, because you might forget in that moment if you're in the middle of labor. Then having another adult who's aware of, like, okay, at this point when I'm seeing this happen with my glucose, then for example, I'm going to shift to this other profile, or I'm going to adjust these settings to these new numbers. It's really helpful to have another person if possible. So the written document, another person who is just like they would be well versed in how you're planning to breathe and your stress reduction techniques, right? It's just another piece of that plan that you can put together. And I just want to throw out there, there's not a right or a wrong. So some people, when we're working with them, they'll say, you know what, I worked really hard before conceiving all the way up to this point. When I get to the hospital, I just want to deliver my baby and let the hospital's protocols
Yes.
manage my diabetes for me. I just need
Hmm.
that
Hmm.
mentally. And that's okay. That's an
Yeah.
option.
I've had a handful of women who've actually chosen to say, this is the time when I want to forget my diabetes. Like, this is the birth of my child. I want to be fully in just for delivering my child and focusing on this and working with my doula or working with my partner. We've got it figured out, but can you just take my diabetes right now? Can you just use your protocol? And I think the worry in that, from what I've gathered in talking to so many women, the worry is that they don't know what they're doing.
As
And
well
that's
as
not
a
true.
woman with diabetes does their own
Correct.
diabetes, right? No one
And
can
it's
do it
not
like you do
necessarily
it yourself.
right. Nobody's going to do it in the very intuitive way that you've figured out your sixth sense of your own diabetes management. Nobody's going to be able to do that. But the hospital does have a very good protocol for
Right,
keeping you contained. And it's the reason that there are insulin drips. There are reasons that there are really good algorithms that insulin drips are driven by. It will keep you safe. It may not be the way that you do it, but if you truly want to be able to step away and really focus on, I'm having a baby, know that they do know what they're doing with that protocol because it has been approved usually by the endocrine department or the head of endocrinology in order for it to work well.
right. And really, in a hospital system, it has to get approved by a huge number of different groups for safety and
Correct.
legality. So, like the pharmacy and therapeutics committee, and the chief nursing officers, and the chief medical officers, and so
Yes.
on and so forth. Like a large number of people have to review it. And then in larger hospital systems, at least, then it is reviewed for safety. So they'll look at frequency of hypoglycemia on it and adjust the protocol over time to improve it. So if you're unsure, or if it's a smaller hospital system, it's totally fair to say, tell me about the protocol. Tell me what
Yes.
the hypoglycemia rate is when it's used. Tell me when it started and when it stops. And can I shift back to my self care if I don't like what's happening with the protocol? You can ask all kinds of questions ahead of time so that you know what your options are, which is, and likewise, you can say, I think I want to do this on my own and manage, and then partway through say, forget it. I want to use the hospital protocol. That's okay too.
Right. And something else that I think is valuable to have written into that plan that you discuss with the team and then even go into the hospital with your written documentation of, what the plan is and that your endocrine or your maternal fetal medicine has kind of signed off on you managing. The second piece to that management is often the spouse or the significant other, the partner also knowing what the plan is. Very much encourage the partner to understand the button pushing, where to find things in the pump, especially. If you're MDI, it's a little bit of different written protocol. But if you're on a pump, and that partner should really know at least where to find what your system management strategy is, what buttons to push again.
Yes.
And protocol, of if my partner can't do it or doesn't want to do it because they're so like out of it with what's going on with me, then now you please take over hospital system.
Yes. Yes, that's a good safety net. Like in my case with my husband, he's normally it's my diabetes. He's there to support me when I tell him I need assistance or if he's closer to whatever I want for a low glucose or something. That's his interaction with my diabetes mostly, right? Or he
Yes.
might check in and say, "Did you pack your supplies when we go someplace?" Right? Like that's
Right.
otherwise it's all me. But before I went into labor and delivery for a couple of weeks ahead of time, I talked him into wearing a pump site for a day with no insulin in it, obviously, just so that he could see how to insert it. And I showed him for several days ahead of that how to put things in for dosing, for correcting, how to change the pieces out and insert a new one. So that in case, like, I don't know, in case I was on some medication that made me really sleepy and I wasn't self managing well or whatever the case would be. So that he was really familiar with it. And it was very eye-opening for him because he didn't know the intricacies or the details involved in the steps. And so, some of the pumps now, you push there's a button that looks like you probably push it when you eat, right? But
Right.
some of it's a little more obvious now than
But
compared
years
to,
ago, that wasn't the case at
oh,
all with no.
you had to hunt and peck to get to menus and yeah. But even now though, still it's worthwhile to go through that with whoever the adult is in the room with you that is going to know about your diabetes plan. Have them do some button pushing. Have them play with the supplies so that they have a familiarity with them. And that way you really have a solid second person who can help you take care of your diabetes if needed. And hopefully you don't need any of that. But just
Correct. I
having
think
that,
a basic, even to educate your significant other about, is knowing how to disconnect from your site, right?
yes,
Especially for tubed pump wearers, not necessarily those who wear a pod or, that kind of thing, but even just being able to say, I know how to disconnect the pump. Don't remove the site. I can pull it out. We can leave the site intact. Let's say going into more of an emergency section delivery.
right.
Don't remove the site, just
Yes.
disconnect from it. And if the partner knows how to at least do that, you have saved for after delivery the ability to easily reconnect and get things going again once that insulin drip or whatever is discontinued.
Yes, yeah, absolutely. And I think another important piece to the unknown of the hospital that is important is timing, right? So
Right.
when we're doing things ourselves, we understand if I give this dose, this is when it starts, this is when it's going to work its hardest, this is when it's going to wear off. If I have insulin on board and I'm coming down, I need a little more carb than if I have no insulin on board, for example. And in the hospital setting, if you're on the protocol of the hospital and you're not in charge of it, then you're sort of at the mercy of the hospital staff to be ensuring that they are paying attention to your glucose as often as they should be to adjust the IV drip in a timely fashion to keep your glucose safe. So if you are paying attention to what your glucose is doing, let's say you're not managing your own diabetes, they are managing it, the hospital, but
Mhm.
having that person in the room with you, along with yourself, aware of what your glucose is doing, even though you're not managing the insulin, is important. So if you see something changing, it's heading too low, you can call for assistance instead of relying on them to get to you at their next blood sugar check that's scheduled for whenever. So it just as a safety precaution. Or if you see that the glucose is rising, and the insulin drip is not getting it where it needs to be, that they aren't and you aren't shy about pushing the button and saying, okay, I know you started the standard insulin drip, but I just wanted to remind you that in my case, for example, this was my total daily dose of insulin before I came into the
Correct.
hospital. And so starting me at this drip level of units per hour, I
May
don't,
not work.
so please be aware you may need to rapidly increase the dose different than normal if that's your case.
Which
situation.
is a reason that I find it valuable on, again, the document that I provide for them to share is how much insulin in total are you coming into the hospital utilizing? What are your current rates and ratios, along with the postpartum pattern and information about what insulin needs are expected to be like after delivery? I think something valuable to bring in here as we talk about IV insulin and the potential for using that, either in the case of you've decided to let them do that, or in the case that it becomes more necessary for them to do that. What does IV mean? Where is that going in?
Ah, yeah, good point. So, yeah,
And
that is
what's the
great
difference, I
point.
should say, from
Yeah.
a pump to an injection to an IV? As you're
Yeah.
talking about how insulin impacts your blood sugar, we have to consider IV is going into your vein.
Bloodstream, right? It is different than what you're doing at home with
Yes.
injections or your pump, which is going in through into your skin and then getting soaked in and eventually making it to your bloodstream. The IV insulin will take, and sometimes people get nervous if they ask what kind of insulin is in that drip. And yeah, which is the kind we don't normally inject or use in our pumps nowadays. But in a vein, it works pretty darn quickly. The impact to the glucose is quicker than when you inject into the skin or if you're using an insulin pump. So it can adjust rapidly when glucose is
Yes.
out of target. The adjustments typically will kick in pretty quickly. Good point. And
Well,
also
and
when
I bring it in because it also goes along with, as you know, your diabetes. You've not ever very likely, or do you ever remember using our insulin and using it going directly into a vein? So, what you know about your insulin response time is definitely going to be different. And this is where the hospital's protocol is written for a reason with safety in mind. They do know what they're doing
right, it's set up
with
and
that, not with your pump, but they do know what they're doing with that.
yes, it's set up in a structured way. There are required timed intervals for blood glucose checks, and they typically will require them to use their hospital finger stick glucose monitor for those blood glucose values. Most hospitals don't use a sensor value. Some do, but most do require the finger stick glucose to be used for calculating IV insulin drips for safety, and that is fair. We've all had a sensor say one thing and do a finger stick, and it's been quite different, right? So you can understand where they come from on that side.
Think Like a Pancreas, the podcast, is brought to you by Integrated Diabetes Services, where experience meets expertise, passion meets compassion, and diabetes care is personal because we live it too. Our team of clinicians, all living with type 1 diabetes, understands the challenges firsthand. We're here to help no matter where you are in the world. From glucose management to self-care strategies, the latest tech, sports and exercise, weight loss, type 1 pregnancy, and emotional well-being, we've got you covered. We offer consultations in English and Spanish via phone, video chat, email, and text. Want to learn more? Visit integrateddiabetes.com or email info@integrateddiabetes.com to schedule a consultation.
What you think about navigating the actual induction versus spontaneous versus a plan for a C-section?
Good.
What does that really look like? Because they all could have different impact on blood sugar. And as we work with women, right, we have a plan for almost a discussion in that labor and delivery visit. We have a plan to talk through each and every one. And a lot of women end up having questions about, am I going to be induced? Well, not necessarily. There are a lot of things that get evaluated for induction. If you go into spontaneous labor, obviously that's what most women really want to do. I
Right.
expect, right?
There's
To
less
just
planning with the diabetes on that side of it because it just happens and now you move on.
there is. And then, for even a planned C-section, I think that there are things to navigate that we can do ahead of that to ensure you're going into that time of delivery with pretty good settings, pretty good idea of what your insulin needs look like, expectations of how soon. We'll move into talking about like that postpartum and insulin needs and how quickly they change. But it is really a quickly moving train at that
Yes.
point. Labor delivery starts, you're going to be delivering soon, and then the insulin need changes. They're going to happen pretty quickly post-delivery, depending on a couple of odd circumstances where it might not.
Right.
But,
Right.
I think it's valuable I usually prep women to say, well, let's say, 2 weeks at least prior to your expected delivery date, if it's 38 weeks, if it's 39 weeks, if they're giving you until 39 and 5, whatever it is, let's really test out what your settings are doing in an environment where you've had a normal day, nothing late meal. Many women go into labor overnight,
Right.
right?
Yep.
Many times, if you're going to be induced, they have you come in the afternoon, late afternoon, evening for an induction to sort of prep the cervical area for softening and whatnot. And then usually it's next morning where they'll do the actual, like, let's get things rolling here, right?
Which means you might not get supper that night, is what Jenny's getting at. Right. Yeah.
Yes. So having an idea, knowing potentially induction is coming, you haven't gone into labor. Yes, this is what we're going to do 2 days from now. It's really valuable to test out that overnight
Mm-hmm.
to
Absolutely.
get an idea of they're not going to let you eat usually.
Right.
And if that's the case, your settings along with maybe the algorithm you're using, having them
Having
more well set can be a gigantic benefit.
Absolutely. And, mentioning that sort of 2 week before the planned either induction or hopeful spontaneous delivery,
Yes.
I like to really re-recommend at least the last 2 weeks, if not four, that someone is really working on cutting back on carbs if they're eating quite a few carbs. Not if they're already ultra low carb, not that situation, but just
No.
normal healthy eating during pregnancy. That last tail end of pregnancy is a great opportunity to cut back on the carbs so that your glucose can be very well managed
Yes.
and your baby is making an appropriate amount of insulin for their own body. And they've got lots of practice not overproducing insulin to cover carb rises that are above the glucose thresholds we're aiming for. And that then, after baby is born, then the baby's pancreas has been sort of trained to not overproduce insulin. And that can be very helpful at preventing hypoglycemia postpartum for the infant.
Right. Because in that postpartum time period, you kind of move into talking about what that looks like. Not only are your insulin needs shifting and changing pretty quickly and pretty dramatically, but the babies, as you just said, if the baby has had normalized glucose, I do the same thing. I really heavily recommend the 2 to 4 weeks before the expected delivery date. It's focus in. If you can cut things out, it's not forever. It's right now. Even things out. Get those post meals really nicely contained so that the baby's pancreas isn't after delivery when the umbilical cord gets cut. And now they are cut off from your ample supply of nutrition delivery.
Yes.
And that changes their glucose very quickly post delivery. It's also a place to just briefly mention newborn blood sugar is
Yes.
very low.
Yes.
And do
If you
not
didn't
get
get born,
freaked out when they
don't
check
freak
the
out.
baby and it's a 48.
Right.
That's a normal blood sugar for a newborn baby.
Yes. The first 24 to 48 hours, newborn baby blood sugars are very low compared to adult glucoses and compared to their own normal glucoses moving forward. So you'll
Yes.
see when the baby is born, they're going to do a heel stick blood test to check for several things, one of which will be glucose. And so if you happen to see the glucose results on the monitor and the nurse looks at it and it's 50 and they go, oh, excellent. It's okay.
You're
Like they
like,
really are right. Excellent. It's fine.
it's fine. Yes. And it's usually, they do 3 within certain time frame. And for the most part, if there is going to be a low blood sugar, most often it's the third heel stick. From the research and the statistics that I've read, and you probably too, it's usually the third that's going to register low. And then there's a transition of, well, what do we do about this? If your early milk called colostrum has come in, usually if you've got a baby friendly hospital, as long as baby's breathing, they barely clean it up and get you skin to skin and encourage you to start nursing at that point, right? Um, and then after that, depending on what the blood sugar is looking like and whether baby has latched well, all the things that are happening by that third heel stick, if blood sugar is low, usually it's a transition of, okay, nursing might not be working well enough. If your baby's hospital has stored breast milk, like
Right.
donated breast
Donating.
milk,
Mhm.
right? They'll usually use the milk bank. If not, they'll usually use a formula. Kind of next step is usually like the glucose syrup, right?
On pacifier. Yep.
On the pacifier, they'll maybe put it under the tongue if you prefer no pacifier. And then really the one that I think most moms are concerned about is my baby's going to have an IV of glucose right away. And it's a down the line. It's not the immediate.
Right. As long as the glucose is within up, they have a protocol for that as well. There's the normal low, and then there's a little too low where they're going to tell you baby needs to eat, and let's
Yes.
try all the things that Jenny just listed out. If it's lower than that, then they might go straight to IV dextrose for safety. Or if baby isn't latching well and taking things in that are being put in their mouth other than the glucose syrup, which would soak in. But yeah, then IV dextrose might be needed. And if it is, it's a controlled environment. They can titrate it down slowly over time so that baby's pancreas has a chance to figure things out and
Copy
make
it.
yeah, and slow down its overproduction of insulin and catch on to what baby's actual needs are. So some babies have totally normal blood sugar when they're born, and some have mildly low blood sugar, and some have severe low blood sugar. So what we can do on the preparation side to reduce the risk of baby needing IV dextrose is the things that Jenny and I just talked about with the few weeks before the planned labor and delivery to work on kind of fine tuning, really becoming the queen of pre-bolusing if you're not a big fan, but for a short time,
You can
sometimes
do it.
we do things we don't like to do,
Yes.
myself included, right? Be very
Yes.
precise with carbs and time it all and keep them corralled to a certain cap of whatever is right for that person, but less than normal amounts of carbs per meal. Yeah.
What then happens? And we kind of talked, I think, pretty well through insulin sort of and transition for the baby to keep their post delivery blood sugar pretty well contained. But what about what happens to mom? If you go online, which I usually tell women, please don't go online and read because you'll hear all the stories about my blood sugar was so low or I needed no insulin. I didn't use it for like 5 days after delivery. I can guarantee you that that is not what happens. Your insulin needs will go down. You will still need insulin. With type 1 diabetes, I've only ever worked with one mom who needed nearly no insulin postpartum, but she had been newly diagnosed pre-pregnancy
Mm.
by only about 3 months preconception. So she was in a very more honeymooning still kind of framework where her insulin needs were near nothing. Your insulin needs will go down, but how fast does it happen? How dramatic is it? What kind of plan should a woman have?
So once baby or babies are delivered and the placenta or placentas as a baby, depending, you need to switch to your new insulin plan.
Yes.
That's how I teach people is
Yep.
everything is out, switch to the new plan right then. Because if you wait until you're low, you're going to be low and then you're
And
going to
it's
have to
hard to
deal with the
catch it.
low and then you're going to miss out on you have a newborn baby that you are working
Yeah,
with here. You want to have your blood sugar up for all the memories, you know. Is that what you recommend? Do you recommend the same thing?
it is. I do. As long as everything has gone well, then usually the recommendation is go ahead and switch or have your partner switch and choose that new profile or an adjustment or whatever you're using, what we've talked through kind of setting up. Do it as soon as placenta is delivered. I usually recommend within an hour at least. Because unlike what you might read online, the drop is not within 2 seconds after delivering, your blood
Right.
sugar is going to tank. It
No,
is by no means that quick, but
it's the
definitely
hormone shifts that happen.
correct. And especially after the placenta is delivered, which is the seat of that hormone production, once that's gone and
All that
disconnected,
progesterone. Goodbye.
it gets washed out, but you still have circulating levels that kind of have to wash out, and then you're transitioned into new hormones that help lactation. And it helps not only that colostrum, but then a couple days later, if you are fortunate, your milk really comes in and you will notice the considerable difference there.
Yeah.
But definitely a recommendation outside of a couple scenarios where there are side things to mention in the case
Like
that,
preeclampsia, for
yep,
example. Yeah.
preeclampsia. And, the interesting thing about preeclampsia is we think about it so considerably in pregnancy. But I've had a number of women, not a lot, but kind of a handful of women who've actually developed preeclampsia during labor or after delivery,
Yeah.
postpartum,
Right.
right? In which case, then there are meds that get used that will absolutely take away the need for dropping your insulin, may actually escalate your insulin need for a
Right.
certain period of time, right?
Yep. And or prolonged the insulin resistance. You might still need to come down somewhat, but not as dramatically as what the original plan was. And
Right.
then over time, as the inflammation decreases and the swelling and the fluid volume comes down and the blood pressure medicines are titrated down, then you'll need an ongoing down titration of your insulin as well over time. What's another scenario is if there's a medical emergency and steroids are involved in
Yes.
the process, and that can throw a new monkey wrench into the plan where extra insulin will be needed instead of less
It's a
early
lot
on.
more.
A lot more.
And it's
Yeah.
not just a little more.
Right.
Steroids, especially infused steroids or injected steroids, in that more emergent need, they're a pretty good dose. And they're going to have a really large impact on your overall blood sugar. It's not going to be long, but it's going to be enough that that drop that you had planned in dose, you're not going to want to use that.
Nope. Gonna wait on that one. Yep.
And, usually what I also recommend if it's not been done is you are in your right to ask for an endocrine consult at that
Yes.
point.
Yep.
If
And that's what I was going to say. If they're administering any kind of steroid or if your glucose is not going according to plan, then request an endo consult. And if the hospital system does not have an endo consult, then at least be in good communication with the team that's been helping you manage your diabetes.
yes.
They should be familiar with the drill and be comfortable with rapidly increasing
What to
doses
do.
if needed.
Yeah, absolutely. Because having that plan, even like the labor and delivery plan, having the plan for a postpartum potential something, you should know, who do I contact for this? Who would I ask for? And like you said, if the hospital system doesn't have it, I need to call the person that I know who knows what to do and take their recommendation or be able to feed it to the team at the hospital I'm working with and discuss why something different is needed.
Yep, correct. Yep, I agree. Yeah.
So once your milk does come in, you might be home already. Or depending on your delivery, if you have a C-section, you may be there for 4 or 5 days, depending on healing and how things are going and how baby is doing, etc. So what ends up happening once milk comes in?
When milk comes in, if you're breastfeeding, every time you breastfeed, there's such a shift in hormones in your body that lows happen. And so you almost have to simultaneously take in glucose treatment while you're breastfeeding. So you get really good at like holding baby and whatever you're taking, like a juice
Nibbling something.
or whatever your treatment of choice. And you really need to work on hydration throughout the whole
Yeah.
postpartum time period anyway. So if you're home, I recommend, if it's possible, to have like a water bottle or a glass with water and something that contains glucose wherever it is you plan to sit most of the time when you're breastfeeding. And in
Hmm.
the baby bag that you're going to take with you everywhere with all the things in it for the baby, you also have to include plenty of glucose treatments and water for yourself because sort of like clockwork. You breastfeed, your glucose is going to go down. It's
And
amazing.
It's an early couple of weeks that becomes where that's most prevalent. It is not the duration of time that you're nursing. It really is, for the most part, what I find about the first month
Mhm.
postpartum,
Yeah,
and the very most, I guess, sensitive time is really the first 2 weeks,
I agree.
where your insulin needs have come down considerably postpartum. Now your milk has come in. You're getting used to a very different schedule,
Yes.
and the shift in the hormones so dramatic in your body. And nursing, which is, as you said, it's pulling out of your body what could be keeping blood sugar stable. And a lot of women actually ask, well, like, how much? It really depends on your milk production and how much baby is nursing. It really, there's no way to quantify, like, how much are you losing to put it back in. What we end up usually doing is just watching for any trends, if there are any, and then really cutting back more. Most often, I find that the postpartum profile that I help women set up for that immediate post delivery time in the first 2 weeks usually needs another 10 or 20% shaved off of it
Agreed.
to
Yep.
accommodate for that early nursing response.
Yep. Agreed. Absolutely.
And
And
then,
then
you may find a time of day that it becomes more of a trend. Eventually, that first 2 to 3 or 4 weeks, I found in particular, my overnights were the hardest,
Mhm.
where the daytime, eventually, I never really had more lows during the day, but I remained so sensitive for overnight nursing that my basal needs were way cut down, and I had a really good protein snack when I went to bed and nursed at my bedtime with baby, right? And then that protein snack helped to hold things along with a really, really low overnight basal rate, because otherwise I was just consistently like, I'd eat, I'd go up, and then I'd come down because I'd nurse, and then it would drop really low and I'd treat and I'd eat again. Like, it was
Yeah.
just, before you figure it out,
It's
you
not
might
fun.
find times where you're more sensitive.
Yeah. And over time, Jenny, you mentioned something important that the sort of more obvious or dramatic insulin sensitive time is shortly after delivery, the first couple of weeks. And the longer someone breastfeeds, the more one, you get your doses adjusted so that
Right.
they're not low all the time. But two, your hormones are going to continue to shift back to getting back to somewhat of a baseline over time. And especially later when you might be weaning baby off of breastfeeding, then your insulin needs are going to be shifting back up again to whatever
Yeah.
your new baseline will be. And that's sort of a hard time because sometimes babies are done breastfeeding because they're now taking in solid foods, or semi solid
Enough.
foods, right? And so that they don't need to primarily rely on breast milk. And the mom is still making lots. And so there's this kind of uncomfortable transition where you're trying to figure out, okay, how often, and now baby's taking less. So now what do I do with my insulin and glucose? And then next time baby eats a lot. So now I've got a bigger drop in my glucose. So it gets a little bumpy before it smooths out again to
It does.
transitioning off of breastfeeding fully.
I find that most often the most sensitive to nursing is going to be within the first 2 to 3 months post delivery, where you might still find some real sensitive times around nursing. You may find a schedule to it eventually as you get further away from delivery. Most often, though, by 3 months and then going forward, you're already developing a bit more of a schedule. Baby may be sleeping much longer overnight. You may have Baby will develop more wakeful times and more known nap times by 3 months plus going forward after delivery. And so that leads to a little bit more stability in what you can expect to happen with your blood sugar. Usually by 3 months postpartum, many women are heading back to work, or they're doing that along with adding back an exercise routine because you're back to feeling like good about having more of a schedule now. It's not so topsy-turvy anymore. And that regularity helps you define where other adjustments might need to be made. The first year of breastfeeding, if you are planning to nurse your child, is really their main nutrition. It's not really until post 1 year where many women consider, I'm going to start the weaning process, or baby is much more interested in food than in nursing. So they kind of self wean, right? And at that point, you're right. Insulin needs, as breastfeeding goes down or your milk supply declines or you take it away outside of maybe bedtime in the evening, your insulin needs usually will shift up. And then depending on where your weight sits in that time period and what activity level you've gotten back to, your shift might be relative to some of that. The other thing that gets put in the mix here, and there is a very wide range of when it happens, is the return of your monthly cycle.
Yes.
That
Yeah.
throws another
Right.
bit into this to manage.
When your hormones start doing their normal cyclical shift and you have to try to pinpoint like, oh, it wasn't a site. It wasn't breastfeeding less the last few days. I was
That's what
ovulating.
that,
Okay.
yes,
Why my
right.
insulin needs going up. Yes. And just to throw it out there, just to make sure in case someone hasn't heard this before, just because you don't have a regular cycle yet, menstrual cycle yet, does not mean you cannot get pregnant. So don't use menstrual cycle returning to regular as your birth control method. If you
And
are
don't
not,
use breastfeeding as the age old. I mean, it, in a way, it's not necessarily 100% a wives' tale, but it is not 100% protection. So don't assume because you're nursing that you cannot get pregnant. That is not true.
throwing that out there because,
Yeah.
again, with type 1 diabetes, we want to try to prepare, if possible, for glucose management before conceiving.
Again.
Yeah. Yeah.
Yes.
So throwing it out there. One thing I wanted to put out on our conversation today
Yeah.
is there is an increased risk postpartum for thyroid trouble to kick in, even in women who did not previously have a known thyroid disorder. And
Yeah.
it's really almost a 25% occurrence. Like 25% of women with type 1 diabetes postpartum may have hyperthyroidism, where their body is cranking out way too much thyroid hormone.
Mm-hmm.
So that was something no one talked to me about ahead of time, and it happened to me. So I learned about it on the fly, and I would much rather put it out there for people to be aware of because that means 1 in 4 of us might have postpartum hyperthyroidism.
Right.
Did you ever
And
have it?
what are I mean, what were some of your symptoms that said something's not right? And were they common symptoms, something that women should pay attention to?
Yes.
I
Yeah.
usually recommend continued thyroid testing postpartum, especially if you had no thyroid issues to begin with. It's often a missed piece that doesn't get checked until maybe 6 to 12 months later when you follow up with endocrinology and somebody's like, oh, let's look at this when you've been feeling like trash and it should have been checked way
Yes.
before that, right?
Yeah. Yeah. So
So,
for
what are
one,
some of the symptoms? What should people look out for?
you want to look for, so at first it seems like a good thing. So some unintentional weight loss. Postpartum, most of us have weight that we want to lose. So if it starts coming off
You're
a
like,
little easy,
yay!
like, yay, I don't know why, but it must be all this breastfeeding. Okay, to
Right.
a point that helps, right? But there's a point. But also feeling really jittery and like when glucose gets low and like the hands shake thing, but they'll shake on their own when your glucose is not low, like you're over caffeinated sort of feeling,
Okay.
edgy, irritable, not sleeping well. You might feel really hot. Your hair will fall out potentially. So that's not much fun. That was one of the things that caught my attention before the shakiness kicked in is,
Okay.
after delivery, at some point in time, you will lose more hair
Lose.
than normal. So you're brushing your hair out, you're washing your hair, and like lots of hair is coming out. That's normal to a point. I ended up losing almost half of my hair. That's not normal. It was a lot. So that's how we knew something was wrong. So I went and got tested. But also, you might notice that your tongue is shaking. Weird symptom. But one of the endos I worked with, he was like, oh, really? Postpartum hyperthyroidism? Stick your tongue out. And I was like, what? So I stuck my tongue out and it's in there shaking around. And he's like, yep, you got it. We don't need to do a blood test. You need medicine. I mean,
Wow.
we did a blood test, really, but
Yeah.
that it was a diagnostic assessment. You could see. Another symptom that's common is frequent bowel movements. So, you normally have your normal schedule of bowel movements as an adult, when you normally go, but you might end up going like 3 times, 5 times, 7 times a day. So, that's not
Okay.
normal. So you'll be
No.
putting food in and it just comes back out. You're not absorbing
Okay.
nutrients. So you feel like crud because you're
Yeah.
not absorbing all of the things you're putting in and your weight is going down, which then can
Dropping.
impair breast milk production if you don't get it treated well. And so
Well, and
some of it
one thing
self-resolve.
I'd ask about too within that with all those symptoms, because it's almost the opposite of what you would think, but with hyperthyroid, because things are getting cleared faster, like it's a heightened metabolic turnover,
Yes.
most often your insulin needs go up. They do
Yes.
not go down,
Correct.
right?
So they went down and then suddenly high all the time. So more insulin, more insulin, more insulin. And then as you get treatment, then your insulin needs to come back down again. So that was extra fun too. So I had it happen
Yeah.
both times. And there are two different disease states that cause it. One is called Hashimoto's and the other is called Graves' disease.
Hmm.
And there's blood testing to see which one is the
You
autoimmune disease causing the excitement. If the hyperthyroidism is mild, then it will self-resolve. You'll be a little uncomfortable. You will not lose half of your hair volume. You will not have a tribulous tongue and not be able to concentrate because you have to poop 8 times a day. It won't be as exciting at all,
hopefully not. No, the
right?
gosh.
Okay. But if you're there, the other thing is that your heart rate, your resting heart rate will go way up. Like mine was 120s to 140s, but it could be faster than that even. So if you're having mild symptoms, you're having a little shakiness. Your heart rate's 100
A little
or
higher.
something, it's not dangerous. They aren't gonna treat it, they're gonna monitor it and watch for additional
Work.
symptoms, and your immune system will calm itself down again usually, and it will self-resolve in most people. In some people, medication is definitely needed or treatment plan depending on
And
what the
then is it a time segment of treatment with the medication that then it does resolve to it very different than Hashimoto's, which tends to require medication for management long term. It's
right, well,
not a
diabetes can cause hyper
resolution.
too. So but
Yes.
it's temporary status. It's due to the postpartum hormone fluctuation that triggers the immune dysfunction. So if it triggers and then it wants to stay and hyperthyroidism is there to stay, like
Is
with
there
Graves' disease, for example, then there may need to be a more permanent
going.
treatment. Yep.
Yeah.
Or they might do an ablation or removal. Usually they do ablations nowadays to stop excess thyroid production permanently. And then you go on thyroid medication forever. So there are a
Yes.
wide variety of things that may happen with thyroid treatment. But definitely if you're having symptoms and you're not sure, like, am I just tired? Am I not eating enough because I'm busy with maybe this isn't your first kid, you have a
Maybe.
couple now, right? Who knows?
Yeah.
Or are you noticing some symptoms that are just different from your norm? Definitely report all symptoms to your OB team. They will be familiar with hyperthyroidism postpartum and your endo team, and they should check for it and just make sure that's not what's happening. And then you can talk through, how significant is this and what's the treatment need to look like? And yeah,
Mhm.
yeah,
I think something else along the same lines that doesn't get talked about enough is the difference really between the shift in hormones postpartum that can create some more inward kind of consideration. Like a lot of women call them the baby blues, where
right.
you're just a little bit more like internally focused. You've got a sort of an ease into spending time with this newborn, especially if it's your first. And you may seem very sort of internally focused and a little bit more quiet. That's not the same as what postpartum depression is.
Correct.
And
Yeah.
I think that it's important to define the differences in knowing that there's a turnover of hormones. You're going to feel a little different. The schedule, the sleeplessness, that's all going to make things shift and feel a little bit weird for some
And
time.
you're probably gonna laugh a lot and cry a lot and maybe in the
Yes.
same minute, and you're gonna be like, "What is going on with my brain? What is
Yes.
wrong with me?" It's the hormone fluctuation, it's a temporary sleep deprivation, all the nerves of trying to do everything you can for this new little package that's outside instead of inside. There's just a lot. Hormone
And you
fluctuation.
also have diabetes along with this, right?
Correct.
So
Right,
you're
you don't get
also
a break from
still
that.
trying to navigate, and it's a baby brain shift too, from really tight ranges in pregnancy to now postpartum where your brain is still on the train of those numbers. And I don't
Relax.
have as much time to focus on this. And so, widening that range a little bit to give yourself a little bit of leeway. But if you down the line, and this is where I think it's missed, initially, women get talked to about postpartum depression, not the change in hormones and the feelings, but just pay attention to this. But it's really more like 3, 6, sometimes even 9 months postpartum, where postpartum depression is more common, but it's missed in diagnosis because nobody asks anymore.
And they're not seeing, and the women aren't seeing their providers as often as immediately postpartum, right?
Correct.
So some of the symptoms that people commonly report with postpartum depression is just like normal depression symptoms are, where you might feel overly tired or not sleeping at all, as it might be. You might feel really irritable. You might not feel a lot of happiness or joy in normal activities. You might be withdrawn and not interacting with family and friends. With specifically related to baby, you might find that you are leaving your baby lay on a blanket or in a baby holder instead of carrying them around a lot. And
Yep.
you might
It's
notice
almost like a stepping away
yeah, the
because that
separation is
emotional connection is disrupted.
correct. Yeah. And so it is very common to have postpartum depression just in general in the world out there and not talked about. So one thing, I'm really glad you brought that up, Jenny. So if we can encourage people, if you're having any symptoms or you think you might be having symptoms and you're not sure, you have to talk to somebody. That's your duty to self and to baby and to the just the world at large. Just please talk to somebody about what you're going through. There's no reason to do that by yourself. There's no shame in it. It's a chemical imbalance in the brain, and it can be treated with talk therapy and perhaps medication if needed, but it's a temporary status. As long as
Yes.
you seek help for it, then there's no long term that comes from it. It's a moment in time, a hard moment in time, right? But you can get help if you seek it out.
Right. Yeah. I just wanted to kind of like the postpartum thyroid issues. It's something that if
It
you
happens.
really don't know what's going on, it's always best to ask somebody, seek help, bring it up, talk through it, and evaluate, is it something to navigate with, like you said, talk therapy or medication, or, and when can I expect this to feel better? It's a little bit different for everybody,
Mhm.
honestly.
Yeah,
So,
absolutely. Yeah. All right. So we've made it
okay.
all the way through. We pre planned, we worked hard during pregnancy, there's delivery, there's breastfeeding. And then eventually, unless you have another baby again, you get back to your body with your diabetes with no other external forces weighing in on your diabetes except whatever life might throw at you. And then you might decide to have another child and you start over again.
Exactly. But, I think the good part about having had one experience, and while we work with many women who come back to us for the second or the third or whatever, as we do, you can see the learning that has been there. And the secondary or the third work that we do with a woman tends to be sometimes more data, sometimes reminding, since we keep good notes, what happened last time? Where can you expect a change to come in? Remember last time we talked to your team about this, or maybe it's a new team. And so now it's reminding them how to talk through the team or a communication component. So, your first pregnancy, I think it's a wonderful learning for so many different reasons. You learn a lot about what you can do. You learn about just how to navigate in different scenarios. And if you do try to have another, or you do have another child, you've got something to build on, which
It's
is
not as
so
I'm gonna say
valuable.
it's not as hard. It's not as intense feeling the second time if you opt to try again because you had to take all the learning on and all the nerves on the first time, but now you've done it, so you know how it can be done. So
Yeah.
coming into the second one, again, it's just remembering and reminding and pulling up what we
Muscle memory, right?
yeah, it helps though because it doesn't feel so impossible or so like I don't believe that this can really be my diabetes management. You know it can be done and you know how
Right.
to do it, which is very helpful.
It
I
is.
agree.
Absolutely. So, if anybody listening is kind of feeling like they could use some support, whether it's during pregnancy or, we work with a lot of women postpartum as well, mainly because it's such a transitional time period as we just talk through all the things you could possibly be seeing and what might happen. We're always here. Consider working with us at Integrated Diabetes Services. And hopefully, you've gained a lot from our 3-part little series here. And it's always here to listen to over and over. I think I always listen to podcasts sometimes a couple times to pull all the information out of them. And we hope that we would be able to work with any of you in the future, right?
Absolutely. We would look forward to you guys reaching out anytime. We're here.
Thank you so much. Have a great rest of your day.
Thanks, everyone.
Thanks for tuning in to Think Like a Pancreas, the podcast. If you enjoyed today's episode, don't forget to like, follow, or subscribe on your favorite podcast app. On behalf of Think Like a Pancreas, the podcast, I'm Gary Shiner, wishing you a fantastic week ahead. And don't forget to think like a pancreas.